Well, good evening, everyone, and welcome to our partnership webinar with the Canadian XLH Network. My name is Dr. Leanne Ward, and I'm a professor of pediatrics and a pediatric endocrinologist osteologist at the University of Ottawa and the Children's Hospital of Eastern Ontario, and we're really delighted to bring this webinar to you this evening. I'm going to just start by sharing some slides to get you all organized. So indeed, the webinar this evening is part of the Triple CBH and Canadian Alliance for Rare Disorders of the Skeleton virtual series of 2025. And you can find out more about our events at bonescanada.org if you're interested. This evening, as I said, we're partnering with the Canadian XLH Network. We always love to work with the Canadian XLH Network. This is such an engaged and vibrant group, and always so willing to share their knowledge, their wisdom, their experiences, and their stories. And we appreciate this partnership very much. We acknowledge this evening that the land on which we gather is the traditional unceded territory of the Algonquin and Anishinaabe people. The Algonquin people have lived on this land since time immemorial, and we're grateful to have the opportunity to be present in this territory. This evening, at the request of the Canadian XLH Network, we're talking about kidney health in this condition, and we're really excited to bring this forward. The kidney, as Dr. Filler will tell us, is a vital organ, of course, and so excited to learn all about kidney health and this particular condition this evening. Dr. Sherry Van Vugt is going to open with some remarks in a moment. She's the president and the chair of the Canadian XLH Network. And then we have two individuals from the XLH community who will be sharing their journeys and perspectives on kidney health and XLH, as well as raising their questions for this evening, June Lather and Danielle Steenberger, and I'll introduce them specifically in a moment as well. My co-chair this evening is Dr. Chelsea Grimbley, who's an associate clinical professor at the University of Alberta in the Department of Pediatrics, Faculty of Medicine and Dentistry. She's a pediatric endocrinologist osteologist at Stollery Children's Hospital, and she's presently working on a PhD in health sciences with a focus on FGF23 mediated hypophosphatemia and other forms of genetic rickets. So thank you, Chelsea, for being with us to co-chair this evening. And then we'll have a keynote address on kidney health and XLH, followed by a Ask Me Anything session with a medical expert. And our keynote speaker this evening is Dr. Guido Filler. And I've known Dr. Filler for many, many years, from when he was at CHIO with me in Ottawa, and he's at Western now at London Children's Hospital, and he's a world-renowned expert in renal health in children and with a particular expertise in XLH. So we're delighted to have you with us this evening, Dr. Filler. Thanks for taking the time. As I mentioned, this evening is being recorded, and if there's anything that you would like us to edit out before we post the final recording, you just have to email me and remember what it is that you'd like to be removed, and we'd be happy to do that for you. How can you participate this evening? We are hoping that this is going to be a very interactive session tonight. There's a number of things that you can do if you would like to participate. First of all, you can just listen, and that's wonderful. You can also raise your hand and then open your mic when you're called upon and ask your question or share your experience live. Or you can put your question or your shared experience in the chat, and Dr. Grimbley and I will be monitoring the chat and the raised hands to make sure that your voices are heard this evening. We do want this to be as interactive, as I said, as if we were all sort of sitting around in a coffee shop having a nice chat. So that's the ambiance that we're targeting this evening. I'm grateful for the Triple CBH and CARD Steering Committee who works with me and Dr. Grimbley to set the agenda for the learning and experiential activities throughout the year. And these are the members of the committee, which is growing all the time. After the webinar is over, and it usually lasts about an hour beyond the end of these introductions, then the recording will stop and you're welcome to stay on afterwards and just have a little catch up with the XLH community and a little socialization, and everyone on the webinar is welcome to attend. And so with that, I wish you a wonderful webinar indeed, and I will now turn to introducing Sherry Van Vogt. So Sherry is a founding member of the Canadian XLH network. Her daughter was diagnosed with a spontaneous case of XLH in 2008 at the age of 4, and she's been involved in the XLH community since 2011 after attending the very first XLH day in New York City, which is really neat, Sherry. Her focus in leading the Canadian XLH network is ensuring that access to healthcare and new treatments is made available to all Canadian XLH patients. And Sherry lives with her husband and her daughter in Kitchener, Ontario. So, Sherry, delighted to have you officially open the webinar this evening.
Thank you for that. So, like you said, my name is Sherry Van Vogt, and I'm the current president of the Canadian XLH Network, and I'm very excited to be here tonight representing our network. We have 4 key goals at the Canadian XLH Network: awareness, to raise awareness surrounding XLH and to advocate for patients; access, to ensure all Canadians have access to the best possible treatments; education, promoting education amongst healthcare professionals and those affected by XLH; and support, to collaborate with other organizations to support Canadians affected by XLH. And I believe tonight's webinar is our 5th or our 6th with CARDS that we've held in collaboration with CARDS. And so we appreciate so much the work that goes into bringing these webinars together, and would like to thank Dr. Ward, Dr. Grimley, Dr. Ward's team, and Dr. Filler for taking time from their extremely busy schedules to make this happen tonight for the XLH community. I'd also like to thank Danielle Steenbergen and her mom, June Lather, who will be sharing their stories tonight. Danielle is also the vice president of our board, and June has been a member of our organization since the beginning. And Danielle is also the genius behind all of our social media. If you're not aware already, today, June the 23rd, is XLH Awareness Day. Landmarks are lighting up purple from New Brunswick in the east to Vancouver in the west, as well as both the US and Canadian Falls down in Niagara. If you have a chance, please get out, take in the view of one of those landmarks. Awareness is powerful. Advocacy is powerful. And thank you to those who have helped make this webinar possible, and to all the members of the Canadian XLH community who are able to join us tonight.
Well, thank you so much, Sherry, for those kind and warm words to kick us off this evening. So we're now going to hear from Danielle Steenberger. Sherry has already mentioned Danielle. She's the vice president of the Canadian XLH Network, and she, along with her 2 very active and sporty sons, have XLH. Danielle became involved in the network in its formative stages, motivated by her own experiences with XLH, and she's committed to advancing awareness for the XLH community. She lives in Ontario with her husband and her 2 active sons, where she runs her own hair salon. So Danielle, great to have you.
Thank you. Quite the introduction. So as they just said, I'm Danielle Steenbergen, and I am the vice chair of the Canadian XLH Network. And I inherited XLH from my mother, and myself as well as both of my 2 boys have XLH as well. And so we all kind of have a different journey in my house, which has been very interesting. And yeah, it's affected me in many different ways. And I think I am very curious to learn more about the kidney aspect of it all. I know I've been told that I have nephrocalcinosis, but I am wondering if that has improved since being on burosumab. So there's lots of questions surrounding that. That's never been the main focus of my treatment. I find it's always been blood work. Where's your phosphate at? Where's your vitamin D level at? And that's sort of where it's been left. There wasn't a lot of knowledge up until very recently. So even seeing what my children go through, they have a wonderful doctor, Dr. Filler, and an XLH clinic where they now see their nephrologist, endocrinologist, their orthopedic surgeon, dentist, and they get kind of a full workup all at once, which has been very fascinating. We're learning a lot more in a group setting, which has been very interesting. And we've seen the boys go from conventional treatment, such as myself as well, and on to burosumab, and the difference has been huge on our kidneys as far as I'm aware. So yeah, that's sort of my journey in a nutshell. But yeah.
Yeah, thanks, Danielle. It's great, and it's so wonderful to have the benefit of that multidisciplinary clinic, as you mentioned. I think Dr. Filler, you also mentioned everybody's learning, right, in the multi-D setting, not just the patients, but the physicians as well. And the kidney health does tend to be something that's sort of monitored in the background, but Dr. Filler's going to bring that to life today and tell you what it is the doctors are looking at in the background and what the implications are for you folks. So that's
Hmm.
great. Thank you. Does anybody have any questions for Danielle or any comments on anything that Danielle has said? Dr. Grimley, Dr. Filler, anything to reflect on there?
Love to hear what your thoughts are. Like you went from a non-multi-D clinic to a multi-D clinic. I'd love
Mhm.
to hear what your thoughts are as a parent and as a pediatric provider for myself. What are some of the things that you really like about the multi-D clinic? What are some of the disadvantages? And if you had a perfect world, how would you tweak the multi-D clinic to really suit your life and your schedule?
I think, yeah, the biggest bonus is schedule. We get to see you all in one stop, and that's phenomenal. But even bigger than that is just people work, all these great minds working together, right? So, one doctor may have one view about where your phosphate levels should be, but then, you've got the nephrologist there to be like, well, we need to watch this because of, the kidneys, or, it's the collaborativeness is key, in my opinion. When it was spread out and individual, I found that I didn't ask as many questions, that I didn't know, to see you guys in a room together and talking with us and answering questions, it's really changed the game. Really, it's made me a better advocate. You know, I guess that's the best way to put it. I guess growing up, all I had was an endocrinologist, except for when I needed surgeries, and I had an orthopedic surgeon that would come and go, and so to have these different entities working together and making sure, especially dentists understanding and learning from these other doctors is huge as well. That's been a very challenging part of our journey, is teeth. So it's been pretty amazing. I don't know that there's any improvement to be had, really. I just wish it was available across Canada. I think that's the saddest part is, Ontario, we weirdly have a lot of people who have it. So these clinics make sense. But yeah, I know it's not the case across Canada. And now with the adult clinic trying to form, I'm hopeful it'll be a similar experience. It won't be the same, I know, but it's a start in a better direction as well, because I think, even for myself as an adult, advocating for myself is way more challenging because we we just focus on the kids, right? It's sort of what we do. And so it'll be interesting. I hope this adult clinic changes how I take care of myself as well, or how I, you know, pay more attention. I don't know if that
Danielle,
answers.
I remember writing you a prescription to take care of yourself. Remember that?
It's still on my mirror.
Are you filling that prescription?
At
So, Doctor
times.
Dr. Filler, nice feedback for you right here live and recorded about your multi-D clinic. So, congratulations.
Yeah, I should really give the credit to Sarah Lafont, who's our nurse case manager. We have been trying to do multiple multi-D clinics for various diseases. We have one for cystinosis, we have one for NF1, we have one for tuberous sclerosis, and so on. And in my opinion, unfortunately, we are not doing a very good job when patients have multi-system disease and need multiple doctors. And Sarah just said, "Why are we doing this? We should do it this way." And she actually won the award for the best nurse of London Health Sciences Center. And I feel very, very privileged because I nominated her for that, and she deserves that. So it was really Sarah and not us that made the initial steps. And it was very easy. I just dedicated 4 of my Tuesday clinic mornings for this per year. And then we talked to Raymond, we talked to Kevin, we talked to Famdi. Initially, Robert Stein was there before Famdi was hired. And yeah, I think it's actually also for the physician a very rewarding thing because we can toss against each other. Should we not? There's so much unknown, like the whole question, how do we transition young adults to the adult dosage is such an open question, right? Or what do we do before birth, right? The Frame Clinic clearly suggests that it's not a good idea to give burosumab, but to have the mom stop the burosumab during the pregnancy is also very hard, right? And there's just so much that we can still learn. We probably pretty much know the lower therapeutic window, but do we know the upper therapeutic window, right? That's another very interesting question. And we're very fortunate to have a very scholarly team, so we can actually also analyze these questions. And we are blessed with a large number of patients, maybe one of the biggest in Canada. I think at the moment we have 16. We transitioned one, but there was another baby born. So it's actually really nice to have that. I was very fortunate in Berlin. I had 66 patients with that. And because when the wall came down, I got my first consultant job in East Berlin at the Charité, and all of East Germany had their patients sent to Berlin because it was a very small country, right? It fits probably in Elgin County plus Middlesex, and but has 17 million people. And I had always had an interest since then in that disease, and I was also very fortunate to be part of the consortium that figured out what the FACS gene is, right? So that's and I sent the blood of all 66 patients to Corinne Antignac in Paris. So that was very fortunate, and that makes you hooked on a disease because, frankly, the old therapy was not very good.
Hmm. Well, thank you for that background, Dr. Filler. You have a long-standing interest in XLH dating back to your years in Berlin, and it's great that you brought your expertise to Canada and now to London. So wonderful. Let's hear from June now, the matriarch, I think, right, of this wonderful family. And June, we're excited to hear from you. You've been a lifelong advocate for yourself and your family, living in the London sort of area. So really interested to hear on your reflections of your journey with your condition and your questions and experiences with renal health. So please go ahead.
So I'm June Lather. I'm 66 years old. I was diagnosed with spontaneous rickets, I guess, at 5. And back then they did a lot of more unconventional methods to try to stretch your bones and whatnot. And just basically had a lot of surgeries every other year until I was 16. And then as an adult too, I've had several osteotomies. But anyways, I guess my health is more the kidney part. The EFGR has been really good since I've been on the burosumab, though. It's gone up considerably, which is a plus after being on conventional medication for over 50 years. And the damage it did to my kidneys and other parts of my body. Just
Well, you have kidney disease as a result.
Yeah, kidney disease. I had kidney cancer back in 2015. Basically just lost half of my right kidney. But like I said, I've been on the burosumab now 2.5 years next month, and it's done wonders. I'm on a really low dose compared to most people because I also had thyroid cancer in 2011. So I lost my thyroid and a parathyroid at that time. And then 2014, another parathyroid, and then 2018, another one. So each time I lost the parathyroid, my phosphate levels went up and up and up and up. And I needed less phosphate. I went from like 6 a day to 1 a day. And so that was helpful. And then the burosumab, because of that, they started me on a higher dose, but I really didn't need to have that high of a dose. It turned out I'm on probably the lowest dose, 10 milligrams a month, which is pretty low compared to most. But it's nice having not to take medication every day, and I do my injections every 2 weeks instead of once a month like I started out, and which is, like I said, helped my EFGR go up quite a bit. But yeah, just parathyroid issues, of course, and just other health issues because of the heart. And I have a bicuspid heart, which doesn't help matters.
You're a challenging case.
Yeah. Just.
Yeah, I think I'm glad you shared this, June, because it does speak to, the potential complexity of XLH, and associated what we call comorbidities or associated conditions it can have, especially as you get older. You've spoken about the parathyroids, which control phosphate and calcium metabolism, and you've talked about having your thyroid out and how that impacted your parathyroids. I'm really happy to hear your renal function is better on
Yeah.
Boros. And
Now
do you
the
feel?
calcium's gone down though.
Mm-hmm.
I
Yeah,
mean, it's plummeted, and I have to take like 900 milligrams of calcium a day now because it just kept going lower and lower and lower, as it does when your parathyroid doesn't function properly anymore. And so it's a daily thing now, but that's only been in the last year that's happened. It
and
was fine the first year.
do you feel better overall, would you say? Do you feel?
Yeah, I think so. Yeah,
Okay.
definitely.
Yeah, and it speaks to the importance of the subspecialists all talking to one another when you have a lot going on, as in your situation. And Dr. Filler, we'll talk about that interaction between the parathyroids and the kidneys. Dr. Grimbley, do you have any questions for June?
I do. I have a couple. Thanks for sharing your story. My first one was, how did your healthcare providers know that they needed to decrease the dose? So often we'll start a dose, and if we get normal phosphate or phosphate within a large range, we leave it be. Like, did you end up with high doses, or was it that you felt well and they knew that they could try to decrease it? Like, how did you end up on a lower dose?
Yeah, because I've always had regular blood work over the years. Like anywhere, like especially with the low calcium after each parathyroid, I was getting blood work weekly for the longest time, and then it moved to monthly. So they always knew what my phosphate levels were, and calcium and vitamin D. And vitamin D has been really good since on the burosumab as well. But yeah, they always knew what my numbers were, and so do I. I kind of keep track of them myself, and so we knew that the doses were too high for my phosphate.
Like it was causing
levels.
a huge
Yeah,
spike.
it was just making it go really high.
So maybe I can throw some light into this as well. The kidney disease also causes an elevation of the fibroblast growth factor 23 or the FGF23. It actually is in a much larger range than what you would get with XLH, but at the same time, the clotho, which is needed as a cofactor for FGF23, is going down, so it doesn't work on the kidney as much. And when your kidney function goes down to chronic kidney disease stage 4, which is defined as less than 30% of kidney function, then you actually accumulate phosphate. So your case is a little complex, and it may be that low kidney function has contributed to the need for a low dose. And there's maybe not just enough closer there that the FGF23 can do its harm, right? So that may be an understanding for that. I was fortunate enough to do several studies on FGF23 levels in chronic kidney disease, and they are astronomically high, but they don't do much because there's no closer to work with. And so I'm actually curious whether, since your kidney function improved, and that's presumably because the nephrocalcinosis got a little bit better, whether or not you need maybe over time go up again.
Yeah. Right now they want to keep it where it's at, but I mean, I get monthly blood work, so they always know what all those things are. My creatinine, it's been really good lately too, since I've been on the burosumab. It used to be way up in the 130s. Now it's staying at about 108, which is good for me. It's a good number for me. I know it's not ideal, but for me, I like 108.
Yes.
I think that's amazing that it's come down, June, with
Yeah,
time. Samab,
yeah,
that's quite remarkable. As we get older, the creatinine tends to rise, and
yeah,
so I think it sounds like you're overall moving in the right direction. Yeah.
yeah.
Super. Good. Well, listen, thanks for setting the stage, right? We've heard about the complexity of the renal parathyroid axis, phosphate and calcium and vitamin D. And we've heard about your multi-D clinic. So let's move on now to hear Dr. Filler's keynote address. And just so that everybody is aware, as I said earlier, Dr. Filler is a pediatric kidney specialist and professor of pediatrics and medicine at Western University in London. He cares for children with rare and complex kidney diseases and has a special interest in conditions like XLH, but also other conditions, as he mentioned, like cystinosis and many, many others. He's authored over 400 scientific papers. He's internationally recognized for his work, and he's deeply committed to mentoring young doctors and researchers. And now we're witnessing him involved in patient advocacy. So thank you, Dr. Filler, for being here. And let's hear what you have to tell the group tonight about renal health or kidney health in XLH.
Thank you very much for that kind introduction. We go back a very long time, right? You were coming to CHIO when I was doing that. And then I actually took care of the XLH patient, and there was a beginning of the collaboration because when you started, we saw them together until I left, right? So, yeah, so I am very grateful for this invitation. Um, I hope that you can see my screen and that I can go into the presentation mode. I hope that you see one image.
Yes?
Perfect. Okay. So I would like to share our understanding of kidney complications or renal complication in X-linked hypophosphatemia. And really, the point to bring home is that XLH not only affects the bones, it's a bone origin disease that affects the kidneys, but it's really a multi-system disease. You get abnormal teeth, you can even get abnormal skull, you can get even something wrong with how the brain enters the channel where the spinal cord is, or we call it anocordiaria malformation. And it's really a multi-system disease. When you're older, you may also have your tendons involved and maybe have gotten calcified. So it is really a disease that can affect many, many organs. Um, the kidney handles phosphate, calcium, and vitamin D. It also makes the active vitamin D, and the treatment can impact the kidney's ability to manage these minerals, right? So the key complication is that there's calcium wasting in the urine. We also say sometimes it's a high calcium in the urine. And when it gets a lot, then the kidneys can calcify, and we call that nephrocalcinosis, and these are calcium deposits in the kidney. So even without treatment, you can get nephrocalcinosis, and it has always been a question of mine, is the conventional therapy responsible, or is this a feature of the disease itself? But even untreated patients before we had our treatments developed in about 5 to 10% mild calcification of the kidney. And then on conventional therapy, which is phosphate and calcitriol or active vitamin D, 30 to 60% develop calcium wasting in the urine, and about 30% develop calcification of the kidney. On burosumab, the rates are markedly lower. Um, but still, in the original trials, a small proportion of patients showed that the calcium concentration in the urine was elevated. And nephrocalcinosis can still occur, um, especially when they had past calcitriol use. And the highest risk seems to be, at least these are our data, and we're in the process of publishing that, when you actually switch the treatment from conventional therapy to burosumab, or even during the early treatment. So I hope that you can see that. What is nephrocalcinosis? Can you see my mouse?
Yes.
Okay, perfect. So here I'm just outlining the circumference of the kidney, and normally you would see darker black blobs here that represent the calyces, right? You have the cortex of the kidney, and then you have pyramids that go in between, and then you have it looks like a calyx, right? And then it goes into the collecting system. And here you see different stages of chronic of nephrocalcinosis. This would be grade 2A. There is no shadowing, but it's sort of an inversion. Instead of having the black calyces, you see these calcified pyramids. And it's not a big surprise that it happens right there. It can go really bad, and you can have here on that smaller image, you can have a complete calcification. Fortunately, that's not what we see in XLH. We typically see milder form. It's very rare that you even see the shadowing. In Germany, where I trained, we had a classification for it. This would have been a 2B, this would have been a 2A. Here in Canada, that's not differentiated. Um, Stage 3 would have actual acoustic shadowing behind the ultrasound transducer. And they occur in the deep tip parts of of the pyramids. So this is your cortex. These are this is the medulla, and the body uses a trick to improve the reabsorption of the filtered urine. So a normal healthy adult filters about 200 liters of primary urine, and then that gets concentrated to about 1 liter of urine. And you have a part of the kidney functioning unit that is sitting in the cortex, but then you have a loop that goes all the way down to the tip, and the concentration of the solutes around this increases to the tip of the pyramid from 300 milliosmol to 900 milliosmol. So that pulls water passively back into the blood, but at the same time, the risk of calcification increases because the urine gets hypersaturated. And so typically a stone or nephrocalcinosis occurs in the deep part of the medulla and then blobs off into the collecting system if you actually make stones. I have not heard that any one of you had stones, although it's described in the literature. So you all know how burosumab works, and it does increase the active vitamin D, which is normally inappropriately low or normal. And what happens when you switch them from conventional therapy, that the PTH over time becomes much lower. And it's actually, according to our work, that drop of the PTH that may lead to nephrocalcinosis after conversion. And this combination increases calcium absorption from the gut, and with less PTH, the kidney also reabsorbs less of the filtered calcium, and so that leads to more calcium in the urine. That's why I deliberately use the term calcium wasting. And over time, this may then lead to nephrocalcinosis. So Leanne mentioned that, and I don't want to go too much into the detail, but a drop in the PTH leads to increased calcium reabsorption and the urinary calcium increase. And then after the conversion from conventional therapy, or even when starting without any previous therapy, the 125 vitamin levels shoot up, and they may overshoot the normal range, and that can lead to increased calcium absorption. But that's a short-lived thing that normalizes after 6 months. So why involve a kidney doctor? Well, we have learned that particularly when patients had a high PTH at the time of the conversion, and maybe a washout of 1 week or even 2 weeks is not enough to normalize that, because normally the calcium excretion in an untreated patient is low. There can be temporary increase of calcium wasting in the urine, and we really recommend to monitor the calcium levels, and maybe even quite tightly, as we have done every 2 weeks, because we definitely don't want to have new calcification when we started that. And after we learned that, we actually put two patients that had a high PTH when we wanted to start the burosumab. We put them on a combination therapy of medications that help to reduce the calcium excretion, and one of that is hydrochlorothiazide. Unfortunately, that medication has a complication, namely it can cause potassium wasting. So we combine it with amiloride, which is a potassium sparing diuretic, and it really does two things. It reduces the calcium excretion and it makes the urine dilute. And then we also have given kids additional potassium citrate, which envelopes the calcium so they cannot precipitate with other things. And then we adjusted based on monitoring. And those two patients did not develop any problems at all and never got high urinary calcium. And we feel that that's an important observation that needs to be shared with the medical community. So the take-home message is that the XLH really affects the kidneys through both disease and treatment, and hypercalciuria and nephrocalcinosis are potentially preventable. And as was seen in June's story, may be treatable with burosumab because over time that all normalizes on burosumab, and after a while the calciuria goes back to what it is should be, namely low urinary calcium. We really need the calcium in the bone and not in the urine. And burosumab is very effective, but it requires careful monitoring. So the biggest need for a nephrologist is if there either are already nephrocalcinosis, and especially if the kidney function is decreased, or when you have a high PTH at the time of initiating burosumab therapy. And therefore, we advocate for a proactive kidney health plan to prevent those long-term outcomes. As you learned from June, she had probably the nephrocalcinosis for some time, and that led to chronic kidney disease. So, unfortunately, calcification of the kidneys and even kidney stones bear a long-term risk. And stone formers have a much greater risk of developing chronic kidney disease as healthy people. So here's a prospective matched control subject with a very large number of participants. Almost 5,000 were stone formers and about 13,000 were control subjects. It's a strong study because the controls were 2 to 1 or almost 3 to 1. And as you can see, the green line are the stone formers. They developed chronic kidney disease much earlier than the non-stone formers or non-nephrocalcinosis patients. So what can you do? You can ensure high fluid intake. The best thing to drink is water, maybe some milk to get extra calcium. I strongly recommend to follow the new Canadian Food Guide because what most of us are eating, which is a lot of protein and a lot of carbs, is all acid. And the higher the urine pH, the kidney is trying to normalize the pH, right? But the higher the urine pH, the less risk you have. It just must not be over 8. So we don't want excessively alkaline urine. But what happens when the urine pH goes down, then the citrate, which envelopes the calcium, is all used up for buffering, and you don't have anything to protect that calcium goes down with oxalate or with phosphate, and that then causes crystals and stones. So the new Canadian Food Guide says that 50% of what we eat should be vegetables and some fruit, and about a quarter of we eat should be proteins, including the legumes. They're high protein. And then 25% should be carbohydrates, preferably high fiber. And this is a long-standing story about the sodium, but we eat too much sodium. We probably only need 100 milligrams per day, and we eat a lot of salt. And actually, I have a huge interest in that because we're seeing sometimes up to 5 new kids and typically slender girls that get kidney stones. It used to be disease of old men like me. And the World Health Organization says no one must eat more than 2,000 milligrams of sodium per day. Um, we don't have new data, but in 1970, when I started medical school, a kid would ingest 300 milligrams of sodium, and in 2006, in the Canadian study, it was 3,760 milligrams of sodium. So, in those 40 years, was a 13-fold increase in the sodium intake. And I am very fortunate. I have access to sodium MRI. We can visualize how you literally encrust yourself over a lifetime with sodium in your skin, in your muscle, and in your heart. And then what we will talk about in a moment, the conventional therapy were also phosphate salts that are mostly sodium salts. So especially if you have nephrocalcinosis, I would strongly aim for less than 1,500 milligrams of sodium per day, which is actually very hard because most of the sodium is in processed food and especially in fast food. And they put sodium into everything. It's not really a rationale for the fast food or for the restaurant food. That's more acquired. But in the processed food, sodium chloride is the cheapest preservative, and therefore the food industry will never voluntarily give up. And I really recommend to include citrus fruit. Lemon and lime are the best, but also orange juice has been shown to reduce kidney stone formation and maintain a high calcium diet. Really, we want a high calcium diet. That's why I deliberately use the word calcium wasting in the urine, because we need to block the oxalate, which is in a lot of vegetables and so on. And calcium and oxalate form an insoluble crystal that you cannot dilute. And we want to precipitate that in the gut to prevent that kidney stones can be formed and that the oxalate doesn't even get into the body. Unfortunately, the great apes and the humans cannot really handle oxalate. We don't have any enzymes to break that down. And oxalate in the urine is a foe, and the kidneys will excrete the oxalate. So, how do these dietary recommendations help? Well, a low sodium diet reduces the calcium in the urine. That has been shown over and over again. A kidney stone patient must have less than 1,500 milligrams of sodium per day. And also a chronic kidney disease patient should have less than 1,500 milligrams a day. And then the Canadian Food Guide allows you for enough alkali in the vegetables to really improve the urine pH to go between 7 and 8. That would be ideal. And then, of course, your milk would be one source, and you can also get calcium fortified orange juice. So, citrus fruits, in particular, lime and lemon, provide a lot of citrate. I treat a lot of my kidney stone girls with lemon water. That might be a good idea. And a high calcium diet is really beneficial. So we have to avoid saying that you have too much calcium in the urine, because then the mind may think, okay, I have to reduce the calcium intake. We want the contrary. We want a high calcium diet. So, to summarize this part of the lecture, XLH patients are at risk of hypercalciuria and nephrocalcinosis. Burosumab lowers the PTH and raises the 125 vitamin D levels, which could all contribute to the urinary calcium. Interestingly, we found no relationship to the elevation of the 125 levels. It was the drop of the PTH that was highly correlated with the urinary calcium to creatinine ratio. And you can prevent that with potassium citrate and hydrochlorothiazide and amiloride. And Leanne, forgive me, but I don't think you would initiate that therapy. That's a nephrology treatment. And long-term nephrocalcinosis, as we learned from June, can have very dire consequences. And one should monitor the urine calcium and perform regular ultrasounds in these patients. So, but it's really a lot more than bone disease, and you may have so many other problems, skeletal deformities. Sorry, please feel free to interrupt.
I think it's just Lisa's mic.
Oh, sorry. I
No
got to
worries.
figure out how to shut it down.
And no problem. Please feel free to interrupt. I love to have interactive lectures and not just lecture. Um, so um, another complication that you can get with XLH more than the regular population is high blood pressure. Does any one of you have high blood pressure?
I do,
Okay.
but
Uh,
only in the last not like 10 years, less than 10 years, really, 8 years, which
yeah,
is
unfortunately, in Ontario, half of the population over 40 has high blood pressure. And it is probably by and large our diet, and probably the salt intake plays a big role. But also, you have this chronic pain when you are on a conventional therapy or no therapy, right? And that leads to reduced mobility and joint discomfort, and it leads to decreased physical activity. And it can really affect overall participation and quality of life. And physical activity is a very good tool to lower the blood pressure. But when it hurts to do so, then one won't do that, right? It can also result in weight gain because the expenditure of calories is perhaps reduced. And a lot of patients may have to choose a more sedentary lifestyle and work from early childhood because of the chronic pain. And of course, that can also introduce high blood pressure. And I really advocate for very early treatment with burosumab. Sometimes I did it too early, and less than 1 year, we will never get it funded from the government, right? So lifestyle and nutrition are key for the kidneys. So I have always wondered whether the hypertension is also in part due to the treatment. So for those of you who have been on conventional therapy, we are quite limited what we have, right? We have jam phosphate, and there's 252 milligrams of sodium per tablet. So one tablet is 1/6 of the maximum daily allowance just from that. And then in the Fosflax, it's even 496 milligrams of sodium per packet, right? And so one packet is already a third of what is maximum allowed for that. And the sodium definitely leads to calcium wasting. And the reason how that works is that the more sodium you eat, the more the kidneys are trying to maintain that. And as a consequence, there's more sodium in the urine, and that blocks the passive reabsorption of calcium and leads to calcium wasting. Whereas a high potassium diet is doing exactly the opposite. So for getting the filtered calcium back in the body, it's really helpful to have a high potassium diet. Of course, if you have advanced chronic kidney disease, that may no longer work because you tend to accumulate potassium, right? So the sodium delivery in the distal nephron blocks the calcium reabsorption, and then that leads to hypercalciuria, and that is causing the risk for nephrocalcinosis. So a low sodium diet, I would probably universally recommend it unless you have a disease of kidney wasting sodium, which are rare, but they can occur. And then high sodium leads to water retention and increases blood volume, and that raises the blood pressure over time. And patients on sodium phosphate supplementation may be at a higher risk, and a low sodium diet can help to reduce this risk even in children. So I am extremely fortunate. Maybe I'm still the only pediatrician who does that, but we have access to sodium MRI, and we tested all ourselves. And you literally, so just very briefly, how does this work? More sodium leads to more blood volume, that leads to increased cardiac output, and that then leads by increasing the peripheral resistance to increased blood pressure. What you see on the right is a paper that we published a couple of years ago in Pediatric Nephrology, where we looked at the lifetime, I have to say, North American healthy individuals and how they increase the sodium in the whole leg, in the skin, and in the muscle. I did not show the heart, but that has been shown as well. So you have more stores of sodium, not just the extracellular volume, but also you have protein glycan bound sodium stores in the skin and in the muscle and in the heart. Maybe some of you have tasted your own sweat. It tastes extremely salty because you have these sodium stores underneath the skin. And the skin sodium is unfortunately a direct marker for your cardiovascular risk. I wrote a book about this and I spent $5,000 to make it grade 8 readable, um, that showed, based on the Finnish example, which was the first country in the world to really hone in on that. It was because of the high death rate of males in the province of North Karelia or in the state of North Karelia that the government became very interested. And they did it in a very, very good way. They sent a young physician to this state and he listened and so on. And then they found out, oh my God, these men were, and the women too, were eating unbelievable amount of salt. And they introduced laws to force the food industry to reduce the sodium intake. And it is quite astonishing. The onset of high blood pressure instead of age 40 in Ontario is age 60 in Finland. In the last 15 years, they have reduced the population level sodium intake from 3,700 to less to 2,300. Not quite where the World Health Organization wants us to go, but still the impact was amazing. They had lower hip fractures from osteoporosis. They were actually reduced by 50%. Everywhere else is going up. The heart attacks dropped by 75%, and the strokes dropped by 80%. They also had a lower risk of kidney stones and other diseases. And the Finnish government worked with the industry to replace the sodium salts with potassium salts so that they would still have the longer shelf life and still have the profit. If you go in Helsinki, I don't know if anyone has ever been, I love that country. If you go to a McDonald's, you get a healthy meal, right? You get a whole grain rye bun, you get a piece of, you don't get a burger, you get a piece of filet mignon, and it has a stack of vegetables on it, and there's no salt in it, and it tastes amazing. You should try eating burgers like that. Right? So in summary, high blood pressure and sodium in XLH are probably or possibly related to sodium-containing salt phosphates therapy and excess sodium intake. That leads to fluid retention and blood pressure increase. And of course, it doesn't help if you have a lot of pain because then you can't do as much exercise as someone else. And of course, the high blood pressure can also increase the risk of chronic kidney disease and heart disease. So my recommendation is to stay at the World Health Organization recommendation, which say that you must have less than 2,000 milligram per day. Fortunately, we have labels that show you that. But if you actually have nephrocalcinosis, it must be much stricter and less than 1,500. And we probably only need 100 milligrams per day. So take home message, stay hydrated, mostly water. Balance your plate with vegetables, fruit, and protein. Follow the new Canadian food guide. 50% of what you eat should be vegetables and some fruit, not with a lot of salt, the veggies. Watch your sodium, check the product label. Ask your team about kidney monitoring, and you have the power to protect your kidneys. So this is our clinic setup. Now, Kevin unfortunately left for Halifax, so we're in the process of getting another orthopedic surgeon. But actually, it is amazing. We have now some patients for 3 more years on Burosumab, and the orthopedic surgeon will probably become unemployed for our patients because if we treat early, then we can prevent some of these major complications. And if we treat the patients before the age of 5, they also get less abscesses, etc. right? So this is our clinic setup. It's a very nice group to work with. I really enjoy. And also for the learners, it's amazing because they can see all sorts of different phosphate wasting disorders, including tumor-induced osteoporosis, etc., all in one clinic, and they can learn the fine differences between them. So with that, I would be gladly opening up the for discussion. I hope this was helpful. And yeah, I think that's actually a very compelling reason why a nephrologist should be part of the team.
Thank you, Dr. Filler. That was very interesting talk, and thanks for sharing your experience both clinically in the research field, including decades of experience with XLH, with hypertension, high blood pressure, and with salt intake. We have a few questions already. So one of our first questions from Danielle and June is, can kidney function impact bone health or worsen XLH symptoms?
Well, Josie asked in the chat, should patients on burosumab who don't show any sign of nephrocalcinosis aim for these dietary goals? That's a great question, Josie. As a nephrologist, I would say yes, but probably less important than if you already had nephrocalcinosis or if you had hypercalciuria. But I just want to share one thing. Um, you may have heard of Ötzi and other people that were frozen in glaciers, and they were so smart, they pumped out the stomach, they aspirated the urine when they thought the people, etc. And it's very interesting. They had none of today's diseases, and they had 20 times more potassium than sodium in the urine. Whereas when I see a patient with kidney stones, they have sometimes 2.5 times more sodium than potassium in the urine. And they have no increased sodium content in their skin or in their muscle or in their heart. And they have no coronary artery disease, etc. And it's very interesting. They were also not carnivores like we might have think that they hunted all the time. They ate mostly roots and vegetables. And that's quite obvious from the pumped out stomach, from the pumped out um, um, bowel movements, etc. And we probably could live a lot longer if we ate less sodium. And certainly we should be following the the World Health Organization food guide and not eat more than 2000 milligrams of sodium per day.
Thank you for that. So yeah, I've got a few good questions coming in here. So Danielle and June also ask, are patients at greater risk of kidney complications as they age? So what's the relationship between aging and kidney health in XLH?
Well, there's an overall relationship. Yeah. You are making kidney filters. So there are three organs that you cannot repair. Leanne knows very well about the pancreas. You get a bank account of islets in the pancreas. You get a bank account of the little bubbles in the lungs. We call them alveoli. You get a bank account of kidney filters. It's like a registered retirement savings plan. You have a time of deposits. And in the case of the kidney and in the case of the pancreas, it's until 34 to 36 weeks of gestation, and you never get any more. And you are born with with about 1.5 to 2 million kidney filters, depending on the environment, in utero and genetic factors and so on. And you lose about 10,000 per year until you are age 30, and then you lose them even faster. And one of the reasons why we cannot live more than 100 years is that we just don't have enough kidney filters. And so uh, that's the natural occurrence. So I'm 66. Normal kidney function is 90 to 135. My GFR is already 82. And that's actually quite good because on average for a 66, it would be more like 75 or 70, right? So the kidney function continues to go down. Now, when you have conditions that could further increase the risk, then the whole aging goes faster, right? And you lose the kidney filters more. I love to play with AI and I programmed some models. And actually, I then put in all these factors and I assumed that 100,000 kidney filters would be needed to still live. And then I asked the program to do 4,000, 3,000, 2,000, and 1,000 milligram of sodium per day. And it came up with a life expectancy on average of 84 years with 4,000 milligrams, and it increased to 128 when you'd only used 1,000 milligrams of sodium. So I think the benefits of a low salt diet are amazing. Um, and the extra load of sodium with all the treatment or the conventional treatment probably doesn't help, and you get probably microcalcifications. I see Erica asked here about medications for people who have high PTH and high calcium levels in the urine. Yeah, so you can use diuretics like hydrochlorothiazide, but you need to mix them with amiloride and then potassium citrate. But you could also really just have a lot of lemon juice in your diet.
Thanks, Dr. Filler. I have a question maybe on a logistical or national level. It seems like based on the Finnish study, it seems pretty simple to replace sodium chloride with potassium chloride, and we see Mrs. Dash as a seasoning. Why don't we go towards replacing sodium with potassium?
Great thought, right? Or use potassium citrate so that you also alkalize it. Well, that's what they did in Finland, but cost. Salt is dirt cheap, right? And it's the cheapest preservative that we have. You will not get the food industry to do anything voluntarily. You need to have laws and you need to police the laws to make change. The most amazing is probably in Argentina. You can go to a restaurant without remorse and the food tastes just amazing. And, and when you do the mistake, like I did, and I landed in Toronto and had to wait for my flight to London, and I went to a restaurant, I actually threw up because I could not tolerate that salt after having been in Argentina for a couple of weeks.
Is there anybody on the call that remembers K-phos as a form of phosphate supplementation? Sherry, I see you nodding. So your daughter was prescribed potassium phosphate instead of sodium phosphate, Sherry. Do you want to speak to that?
She was. It was because we had attended one of the XLH days in the US, and we were talking to the doctors there and saying what Alice was on, and that she had already at a young age had nephrocalcinosis. And so that's what they suggested she use because of the lower sodium content. And so we did manage to get access to that and had that up until she went on
Was that Scholl's solution?
It was tablets. Was it
Oh,
Yeah,
tablets?
it was and I see Victoria also notes that her oldest took it. So Beach Pharmaceuticals made K-phos #2 when I trained at the Shriners with Dr. Francis Glorieux, who was the pioneer of conventional therapy, calcitriol, and phosphate. We all got access to the American supply of K-phos via Beach Pharmaceuticals, and there was a publication that showed that potassium phosphate, and Erica, you're on K-phos neutral, exactly, same principle. And there was a publication that speaks to Dr. Filler's point that showed that nephrocalcinosis was reduced on a potassium phosphate instead of a sodium phosphate salt supplement. And now with burosumab, we don't think about that. But if there is somebody who does need to be on conventional therapy, then see if you can get a potassium phosphate supplement. Yes, Victoria, that's right. They were brown pills. Exactly. They came in a brown bottle. And I saved a bottle actually. It's in my office tucked away. But I don't know if I will ever prescribe conventional therapy again. I'm fortunate to live in Canada and have access to burosumab. But speaking of that, if I may just say, I do have trainees from around the world, and I do appreciate that they go back to countries that don't have burosumab. So we still need to be training our international colleagues about how to administer conventional therapy. So it sounds like there's quite a few people on the chat who's got experience with KFOS.
back in Germany, we had Scholl's solution for calcium, etc. But it was really hard on the teeth. It stained the teeth, right? So is the
Mm.
tablets better with that?
Yeah, the tablets were fine. You swallowed them whole. They weren't
Okay.
effervescent. So they were really quite lovely. Yeah. And then Danielle and June, actually, Chelsea, it's your turn to ask the question.
Danielle and June have a question about brosumab. So I think June had challenges getting approval for brosumab due to kidney disease. I assume that's similar in my province in Alberta, where if you have hyperparathyroidism, sometimes based on the CADTH recommendations, they consider that a contraindication to brosumab. But June has seen quite incredible response while taking brosumab. What are your thoughts about how to determine if brosumab is contraindicated or appropriate in someone who has chronic kidney disease?
It probably depends on the level of GFR, right? I would think that when your GFR goes down to 30, it will not be helpful because you already accumulate phosphate because of the low kidney function, because less is filtered. But this is Borosumab is the only therapy that actually targets the mechanism of the disease, right? Everything else does not. It's just that the effect of FGF23, when the clotho dithers away with worsening kidney function, it may not be helpful. The other problem is that when you have a GFR of less than 30, that you tend to also accumulate potassium. So the potassium solution may also not be best. So I think prevention is a much better approach than that. I find that June's experience is really worth publishing so that we can gather evidence that even in a situation like that, and when you had a GFR of 150, a creatinine of 150, so you're a fairly petite lady, so I suspect your GFR was about 45 or so, that it still can have a benefit if you do
It
it.
was 41 when I went
41.
on, and now it's about 47 to 49 tops.
That's great. That is definitely an
Yeah,
improvement.
yeah,
So I think that one needs to publish this to convince the payers and the physicians to still in an ideal world, you do that in a research study and you measure the clotho to see whether or not FGF23 still has an effect. I find your observation of that very low dose very interesting because you may only need a small proportion of FGF23 reduction because there's not much clotho left to actually do its bad effect, right? And
yeah.
so probably looking at calcium creatinine ratio in the urine and looking at the 25 levels and looking at the alkaline phosphatase may be a good strategy to look at that. I'm not an adult nephrologist. I finish at age 18. So I don't know, Joe. Leanne, do you have experience with older patients?
Well, I don't in prescribing, but I certainly, June and I discussed back in the day, didn't we, June, about your situation and the use of burosumab. And correct me if I'm wrong, June, but I remember the conversation being something like we did think the conventional therapy was hard on your kidneys, and we thought that trying some low dose burosumab, making sure we didn't pop you into hyperphosphatemia, or if we did to get the dose down, that it was worthwhile under very, very close supervision of your attending nephrologist. And it's really nice to hear that you've had appropriate dose titrations to get to a point where your kidney health is better. And I agree with Dr. Filler. I think your situation, which is also complicated by the hypoparathyroidism, is worth describing to the world to speak to your evolution, and that should also include just how you feel, your energy levels, and so on. So that I agree with Dr. Filler. It's quite interesting what you've experienced, June.
Yeah, definitely.
I think that's another thing, though, if we can just sidebar this for a second, was getting her doctor to understand that maybe starting at the 60 that she did was not wise in this scenario, right? Like that, it really made her sick initially. And it took you, I think, advocating as well as
Yep.
her to get her nephrologist to acknowledge that this was too dangerous of a dose. And instead of just removing her off this drug, to come down and down until they reached 10 milligrams. Because it was so
70 to 60 to 30 to 10.
Yeah. And
unfortunately, FGF23 was, or the FAX gene was cloned more than 20 years ago, and it's still not in the curriculum for medical students. So when I ask medical students if they know what FGF23 is, they look at me as if they would look at the moon or Saturn, and it's very sad. And then that interplay between clotho and FGF23 is not, most physicians are not familiar. Even nephrologists don't do that. It is unfortunately very sad, but new knowledge may take 25, 30 years before it's getting into the curriculum. And I would have actually started you on a very tiny dose because of the understanding that they need clotho to even have an effect, right? Ideally, would have even measured your FGF23 levels to see how high they were. And then you have to always look at the relationship with the phosphate, right? Because with 41, you could start to accumulate phosphate.
My phosphate levels were about 130 at the time of starting burosumab. So I probably should have been on a lower dosage to start because of that alone.
Yeah.
And that was with taking one phosphate a day.
Yeah. And waiting the 2 weeks before starting taking none. So I guess
phosphate and burosumab together?
No, I stopped taking it for 2 weeks and then went on burosumab.
But it was still at
it was still up at a high number. So
yeah, you probably have you probably had already a little bit of accumulation of phosphate that you got away with a normal phosphate of 1.3 with a tiny dose, right? So the problem is that these nuances in the dosing of burosumab are very poorly described, and you get 0.8 milligram per kilo for a starting dose for a kid, and so on. And I think we need to be a lot more nuanced about what the starting dose should really be. We have to look at sex, we have to look at the volume of distribution of the antibody to get a bit smarter about it. And you're absolutely right. One would have to adjust it also to the kidney function.
And I'm about a 90 now, like 0.90 now on the burosumab as an average.
Yeah, that's good.
Which is good.
Yeah, that's great for an adult, low for kids.
And a low dose of burosumab. So that's a pretty good number.
Yeah. No, that's good, June. You've had a nice evolution there with careful monitoring and adjustments and collaboration and dialogue among physicians.
Yeah.
That's good. Alida, you're talking about Windsor half salt, which is sodium, potassium chloride, magnesium carbonate, potassium iodide, and calcium, probably citrate, I imagine.
Yes.
That's quite a little concoction there, Alida.
Yeah, well, I'm sort of a salt addict, and I decided I needed to decrease my amount of sodium. So I started using this quite a few years ago, and I don't eat maybe one meal a day where I use sodium, and I don't eat processed foods and so on. So I've been using this. I find now when I eat regular sodium salt, it's just a little too salty. And but I saw a new endocrinologist last month, and during the talk with her, and she had a couple of other physicians there, they started discussing that I was in stage 4 kidney failure, which kind of upset me. So because my GFR was 27, which was lower than ever. And so when I was researching kidney function and so on failure, it said one of the things was not to ingest potassium. So now I'm wondering, I'm sorry. I'm learning so much from this webinar right now, and there's so many things I want to ask, but I have to go back. There's so many things in my mind. I need to go back and look at it all over again and rerun it because, and sort of go step by step. But I'm just wondering now, should I be stopping taking this, using the salt? And I'm also an HCT as well. So there are a lot of questions there, but this half salt, maybe it's not something that I should be using.
I can help a little bit. So your nephrologist will regularly check your potassium.
I don't have a nephrologist.
Oh,
I'm 77 years old. I finally at age, I guess in 2019, 2018, 2019, a little bit more, it's May 2017, I got in touch with a rheumatologist and I had a rheumatologist, and then I joined Dr. Ward's study. So I have never had an endocrinologist until, I guess, 2020, and now he's retired. So I have no other rheumatologist, endocrinologist, or nephrologist. So
okay, but your GFR of 27 is lower than it should be for your age.
It certainly is, yes.
And it is chronic kidney disease stage 4, which is defined as 15 to 30.
Right.
And you start to accumulate potassium when the GFR is under 30. So, I mean, you're only using it very sparingly.
Right.
So, we need, in a case like yours, you should have your potassium checked at a very minimum every 3 months, ideally more often than that, because high potassium can be very dangerous, and you may not have any symptoms from it.
I haven't had any of my electrolytes when the blood work's done. I haven't had the electrolytes done with that, so I don't have any, I don't have any basis to go on from previous blood work. Yes.
Well, I think that it's not safe, and as Leanne just said, we need to find you a nephrologist. Where are you located?
I'm in Bobcaygeon, north of Peterborough. I'm seeing my new endocrinologist next month again, so I will look into all those.
Please ask that endocrinologist to make a referral to nephrology.
Yes.
The kidney function needs to be monitored, and with that low GFR, you may need the blood-forming hormone. You may need even phosphate binders potentially. This is a bit tricky. I would be careful with this, especially as it's a concoction of different elements, and magnesium can also accumulate when the kidney function is low.
Okay.
So those things all need to be checked. All your strong ions need to be checked on a very regular basis, and the adjustment has to be made accordingly. I treat only children, but when the GFR is 27 in a child, I usually have to restrict the phosphate, or I always have to restrict the phosphate, and I have to usually restrict the potassium.
And I'm not on phosphate or anything else, so it's okay.
That's okay, right? But be careful with potassium and magnesium.
Okay.
High magnesium is not that dangerous. It's more dangerous when you have a low one, right? But we need to find your nephrologist, and probably you can find a nephrologist in Peterborough. So,
so I'll stop using this. But is this a possible thing for other people to use, or?
Yeah, there's also a no salt from Windsor.
Yes, right.
Which is even more of a concoction of different other salts. I think all of that is unfortunately very understudied. If you just want to put a pinch of salt to your potatoes, I think that's not harmful.
Right, thank you. This is very interesting, and there's so much there that I've got to relook at. So thank you.
Well, I'm glad.
Thank you, Dr. Filler, for being so generous with your knowledge and your expertise. There's another question from Danielle and June. They're asking, in children, how early do you see kidney issues appear? And how do you balance the need for phosphate and vitamin D therapy with the risk of kidney calcification in children? And for sure, if you can't get funding or if you're in an area that doesn't have funding for brosumab.
That's a great question because the access to very sensitive tests to measure kidney function decrease is limited. In Edmonton and Stollery, you have cystatin C, but in most centers, we don't have that. Cystatin C is a superior marker for measuring kidney function. It's also totally independent of muscle mass, versus for creatinine, you have to use in children a height creatinine ratio to even interpret the creatinine, and you have to be a bit knowledgeable about the muscle mass of the patient. But that is, creatinine doesn't go up until you lose 40% of your kidney function. Cystatin C goes up immediately, but it's very limited, even though all the guidelines say that you have to have both. We are regularly measuring the cystatin C in our patients, and there is currently no patient in pediatric age range that has a GFR of under 90. Now, would we like to have maybe more GFR of 110 or 120 in that pediatric age range? Yes, but nobody has under 90. And I watch that like a hawk. I would strongly recommend, because often XLH patients are very muscular and the creatinine may be foolish in the interpretation, that one measures both cystatin C and creatinine, but unfortunately, because of how the labs are funded in North America, in Canada, which is the only country where having less tests makes more money, uh, it's very limited. It's really only Edmonton, Geo, and here that have that. Not even Sick Kids has it. But I want to reassure you that there is not a great risk in childhood to have decreased kidney function. This is more later in life.
Oh, there we go. I think we have time for one more question. Danielle and June again, they're asking, is sea salt or Himalayan salt better options? Okay.
Unfortunately not.
Darn it.
Do you love salt, June and Danielle?
Not me.
No?
I like cooking my meat with salt for sure,
Sure.
but not like obscene amounts, to be clear. Just in the mix.
No, I limit my intake. I don't put it on any of my food.
You're on Barosumab, so 2,000 milligram is probably fine.
I don't think I'm hitting that either. That
Yeah.
seems like a lot of salt.
It does.
No, but the cooking salt only accounts for 10%. The vast majority, so bread is a high salt, it's not a high salt food, but because we usually eat a lot, it accounts for 26% of what we eat, of our sodium intake. But most of that comes from processed food. So if you cook from scratch and add a pinch of salt to your meat, that's perfectly fine. Yeah.
We've been eating pretty clean. You'll be happy to hear that.
And the other thing you can do is add spices.
Yes, for sure. We're a big spice family.
Wonderful. Great. Dr. Grimbley, do you have any final questions for Dr. Filler here as we wind down the call? And then I'll open it up to the community and see if they have any final burning questions. Dr. Grimbley?
I do have one more question that I see clinically and that I think some of the people in the call might be interested in hearing. But you talk a lot about urine calcium and measuring that. I follow a lot of urine calcium, but I do it as a spot to urine calcium to creatinine. I think it is more accurate to do a 24-hour urine collection, but that's so challenging. So do you find a spot urine collection accurate enough, or should we really be asking people to do a 24-hour urine to calcium collection if we want to protect the kidneys?
So we just do the urine calcium to creatinine ratio, consider the age dependency of it, because it goes down from a newborn to much, much lower values. So if you use the SI unit, an adult may have 0.1 or 0.2 as a ratio, but for a newborn, 2.1 could be normal, right? So it's a curve that goes down just as you recruit the kidney filters after birth. it is not as accurate. You're absolutely right about it. But I find that even in adolescence, maybe 13, 14, it's still not very reliable. They miss urine proportions of it. And it gives you still a pretty good uh, idea. What I would add, if you are open to this, is also add a sodium and a potassium in the urine. And ideally, you want to have more potassium than sodium in the urine. And certainly, if the sodium is 2.5 times more than the potassium, then you have a risk of stone formation, even without any hypercalciuria. The very many patients we see with kidney stones, which is very disturbing, they often have no hypercalciuria, but they don't have enough citrate in the urine to envelope the calcium. So I also always get a urinary citrate, and if the calcium to citrate ratio is more than zero point 0.7, it also disposes to stones and nephrocalcinosis. So a high citrate intake or a high alkali intake, which you can achieve with vegetables, is also really good for kidney health.
Think we're all going to go and buy some lemons and limes, right? And squeeze it into our water and increase our citrus intake as a result of this tonight. And think about the next time I'm putting a little salt on my fries with my burger, I'm going to be thinking of you, Dr. Filler. So great. Any last questions from the community before we start to wind down the call? Comments? June and Danielle, you get the last word. Oh, you're on mute.
While you're thinking,
Oh,
was
sorry.
this helpful? Was this helpful?
Yes.
Yes,
Very.
absolutely. Yeah.
Very.
Again, like I said there, to open up, it's not ever really been in the forefront of my treatment anyways. It's certainly not the case with the boys, but like, I definitely had more of a mild XLH experience up until my adult life. And it's very interesting to know that there's so many different components that we need to be paying attention to. And certainly kidneys are a huge part when you think about their role in how our body functions. So no, this was really wonderful to have you come and share all of your expertise with everyone, and thank you for setting this all up. Really appreciate it.
I think renal health is just good across, the lifespan in general. We think about there's a lot of attention to heart health, right? And protecting our noggins, wearing helmets, and, making sure our brains stay active. And I think just thinking about renal health in general, in terms of diet, as you've discussed so nicely, Dr. Filler, and keeping our blood pressure down and trying to manage our weight and our activity levels. Like this is just good health across, in general, let alone in XLH.
Yeah.
June, you were going to say something there.
No, I'm agreeing with everything you say.
Okay. Very good.
I also really agree that this has been so helpful. I know for me, my high PTH and then I've had high calcium output. And so I've been trying so many doctor's appointments the last few months. So trying to figure that all out. But right away when I got on the call, you guys were talking about that. So helpful. So thank you so much.
Well, Eric, it's been great to have you. I don't think we've met before, and it's always great to have a new voice on the call. And of course, we're delighted if there's even one little morsel that you take away it makes it all meaningful. So, with that, I think we'll wind down the call, and I just want to thank Dr. Filler. I want to thank Danielle and June, all of you for posting your questions, sharing your stories, Dr. Grimbley for co-chairing, Sumay and Nazrin for helping to organize, and we always look forward to the next time we're all together again. So thank you very much. Till next time.